Okay, so the place started recording now. Okay, yes, recording started. So here, what we discussed, like previously, the sympathetic and parasympathetic system, and from where it comes is from autonomic and the peripheral nervous system, and like the efferent and the efferent divisions, and what is pre and post ganglion for parasympathetic and the sympathetic activity, like smaller in size, and post ganglion is larger in size, but whereas in parasympathetic it is like the pre-ganglion is bigger when compared to the post ganglion. And next, coming to the drugs, the pharmacology part of this parasympathetic activity of drugs which are acting on autonomic nervous system. Basically, the drugs which is acting on autonomic nervous system, these are the drugs that reduces the majorly functions. Like here, last time what we discussed here, like we discussed that in the previous slide, the parasympathetic activity is because of acetylcholine, but whereas the sympathetic activity is because of epinephrine or norepinephrine or adrenaline. Okay. And this acetylcholine, from where we get this acetylcholine, is from the nerve ending. We release some acetylcholine by a mechanism of synthesis. I think we will be just discussing that and how it is getting released and what are the functions of acetylcholine in different body organs and the body functions, like how it's playing an important role over in the body. Okay, and then once it is like on what neurotransmitter and what type of receptors it is going and binding and showing some functions. So we will see what is parasympathetic system, what is and what neurotransmitters are involved. So here, before we go further for these neurotransmitters, what we will be going to discuss, I just want to raise a question that what is a neurotransmitter? Any idea what is a neurotransmitter is? What is a neurotransmitter? A neurotransmitter is a chemical substance that is secreted by the neurons of the nerve ending in the synapse. And like here, like what is the, like here, what I will say, a best way of communication for the humans is like when we talk, we communicate with each other, isn't it? Whenever we are talking, we are communicating with each other, isn't it? So it is a way of communication. So here, when we talk about like sympathetic or the parasympathetic activity or any other body function, the body organs, how did they communicate with each other? By means of a chemical substance that is something called neurotransmitter, or by means of chemical substance that is called neurotransmitters. Like each neurotransmitter, like suppose acetylcholine, norepinephrine, dopamine, serotonin, GABA aminobutyric acid, GABA, okay, thyroxine. So these are all the some neurotransmitters and the hormones. They communicate with each other in the body functions, and they will maintain the body functions in the normal way. Okay, so here the parasympathetic activity, which is like parasympathomimetic, that is like here. So here, before we go for parasympathomimetic, let me tell you the parasympathetic. So if you see parasympathetic here, parasympathetic, parasympathetic. What is this parasympathetic? So okay, I'm not writing full. The parasympathetic is subdivided into agonist and antagonist. Okay, antagonist. Okay, agonist. Okay, this is not very good. Okay, I think I can write the text also here, I suppose. Yes, here it is. This makes the things easier. Parasympathetic. Okay, and I just draw a diagram here like this, agonist and antagonist. So here, text here is agonist and antagonist. Okay. Okay, this is spelling mistake. So here, parasympathetic system, it's agonist and antagonist, isn't it? So agonist means like here, anything anything which is stimulating the activity. So whenever the agonist, any neurotransmitter or any ligand or any substance that comes and binds to the receptor, what is receptor? You might have seen. So suppose this is a cell. On the outer surface of the cell body, there is something called receptor. What is receptor? Receptor is a macromolecule which is made up of a protein. And anything, any ligand, any neurotransmitter drug or anything, whenever it comes and binds to that receptor, so suppose this is the neurotransmitter acetylcholine, is binding to the receptor. If suppose it is going some function, some changes, physiological changes, then it is agonist. If suppose it is not undergoing any physiological changes or blocking the action, that is something called antagonist. So here parasympathomimetic, mimetic means mimicking the action. It is mimicking. Mimicking means stimulation. Mimicking means stimulation, means increasing the activity, showing some synergistic effect, showing some synergism. So that is thing called mimetic. That is right. Okay. And then if suppose it is blocking the action, if it is blocking the action and that is inhibiting the action, that is something parasympatholytic. Parasympatholytic. Lytic means stopping the action. But whereas what we are discussing here today, drug acting on autonomic nervous system, parasympathomimetic means the first one, which is right, that is agonist effect. Whenever the drug goes and bind or neurotransmitter acetylcholine go and bind to a particular organ, based upon the binding of that acetylcholine on that particular organ, the activity will be increased or decreased or physiological changes took place in the body or not. Okay, if I make myself clear for this point, then we will go for the further slide. So what is parasympathomimetic? Now I think you will be clear like what is mimetic. Mimetic means it is showing some effect which is synergism or stimulation of that particular receptor whenever a stimulus to that receptor. Clear? So here, parasympathomimetic, these are the drugs which produce action and similar to as that of acetylcholine and directly or indirectly activation of receptor. So whenever the acetylcholine is going and binding to the receptor, it can activate directly or it will activate indirectly anything. Okay, by activation of that particular receptor. So this directly acting that combines with cholineceptors and in the same way as that of acetylcholine, and indirectly acting which will be by cholinesterase inhibitor or binding of cholinesterase enzymes, and that will be causing in the same way as that of acetylcholine binding. And this parasympathomimetic can also be known as cholinergic agonist, parasympathomimetic, or cholinomimetic. Why? Because it is binding to the cholinergic receptor, the choline. It is from the choline. What is choline? The choline is a precursor for the production of acetylcholine. That if you see the synthesis of acetylcholine, I think if there is a synthesis like here, it is in upcoming slides over here. The choline is okay. Acetyl is combining with choline and forming acetylcholine in the nerve ending. Okay, this is a process that is something choline. So that's why it's called cholinomimetic also. Okay, that's why it's under the name. So here the acetylcholine is like here called by 3 or 4 different names. So don't get confused. It is the same thing. Like suppose one student, I'll take an example of the name what I can read more easily. Here the name is Khalid bin. No, okay. Where he gone? He finished. Okay. Says it was Khalid bin Ahmad. Okay. Khalid bin Ahmad bin Idris Ya Bajawi. Okay. So here, like I have told you, the one name is like Khalid bin Ahmad bin Idris. I think if I'm reading Arabic properly, I'm not perfect in Arabic reading because there is no zales over here. So here, this is the one person. If I call him Khalid, or if I call him Ahmad, or Khalid bin Ahmad, or Ahmad bin Idris, or maybe Bajawi, the surname, the name of a person is same, isn't it? Like suppose, for example, like my name is like Muhammad Abdul Hakim Siddiqui. So if you call me Muhammad, it's me. It's Abdul Hakim, it's me. Siddiqui, it's me, isn't it? So one person is having like 2 or 3 different names, like bin, like etc. like that. When you're calling him by the first name or second name or maybe the family name, the person name will be same, isn't it? So this is like, suppose it's the same thing, but the name is like little bit two or three names what we can call, like suppose parasympathmimetic, cholinergic agonist, and cholinomimetic. So it's all the major neurotransmitter which is involved is same acetylcholine. It's just a different names for us. Okay, it's just a different name based upon whatever we prefer calling it. Okay, so here the neurotransmitter in parasympathmimetic, here the acetylcholine will go and bind to a particular receptor and activate the receptor and make some physiological changes that may arise. Okay, next coming to the slide, next slide is cholinergic receptors. What are the cholinergic receptors? These cholinergic receptors are the receptors which are having binding to cholinergic neurotransmitters. Cholinergic neurotransmitters. Okay, what are these cholinergic neurotransmitters or the receptors are? These cholinergic receptors are, why now here, just now we said parasympathmimetic and now we said cholinergic agonist and cholinomimetic. So now we are using the term cholinergic agonist. Now we are using only cholinergic. So what are these cholinergic receptors? These receptors are nicotinic or the muscarinic type of receptors. Nicotinic or muscarinic types of receptors, or these also called as acetylcholine receptors. Acetylcholine receptors, where the acetylcholine will go and bind to the receptor and show some body functions. So here the nicotinic receptor is basically divided into NN. Nicotinic and the smaller n, nicotinic, and the M, which is like nicotinic muscular area. But whereas the receptors which is like muscarinic, which is like M1, M2, M3, and M4, M5. Okay, so here what we are majorly concerned about the nicotinic muscarinic receptor M1, M2, and M3 for our basic study. So, and now we will see where are these receptors are present. So let me just tell you, like maximum all of these nicotinic receptors, all of these receptors are G protein coupled receptor, GPCR. These all the muscarinic receptors are G protein coupled receptor. It can be G stimulatory like GS, GI, GQ, GIQ, GI12, okay, etc., etc., or like receptors like it can be G protein or it can be ion channel. Okay, so based upon like maximum of them are G protein coupled receptor based upon the activity. So here we will see what type based upon what receptor which is present on which site and what are the different body functions will help. It will show some different physiological activities. So based upon what receptors are present and where they are present. So this first, the muscarinic receptors, like here M1 type of receptor, muscarinic 1 receptors are present in autonomic ganglia and autonomic system, gastric glands, but whereas M2 receptors are present in the heart, especially in the SA node, AV node, in the atrials, in the ventricles. Okay, and here M3 types of receptors, which is present in the smooth muscle, eye, exocrine glands, and in the endothelium of the vascular endothelium in the cell or inside the cell. Okay, endothelium layer or the blood vessels or wherever it is. Okay, so based upon where they are where they are present, they have a different activity. They will show some different activity. Okay, and the next receptors are nicotinic receptors. As we discussed, nicotinic NM receptor. This is a neuromuscular receptor. I told you NM. The M mane muscular, say muscle, the bodybuilder. So this is a muscular junction, and it's working like suppose all the neurons, which is like suppose all the cell bodies which is present all like in a small area. So at the neuromuscular junction, say example, something like that. And nicotinic receptors, they are present in the autonomic ganglia, central nervous system, and adrenal glands. So I should not tell you where the adrenal glands are now because it is just above the kidney area at the tip of the kidney. Okay, bean-shaped thing what I have just told you. And from where does we get this acetylcholine? The acetylcholine is a neurotransmitter that we get it from a synthesis which is occurred in the body. Okay, and this choline, okay, before the synthesis, what are the function of this acetylcholine whenever it binding? So here these are the different drugs which is binding directly to the acetylcholine receptors are acetylcholine, beclothon, pilocarpine, and these are the drugs which is directly acting on it. And whereas the indirectly acting drugs like acetylcholinesterase drugs, that is reversible, irreversible process. What is reversible and irreversible process? So here, when you study reversible means, if suppose a receptor, a drug has been bound and bind to a particular receptor, okay, and that means, and then if that receptor is been occupied, okay, and reversible, and we are talking reversible. What is reversible? So if suppose any external force of the any other drug will come and replace that site of that particular, so I will draw with another, say suppose blue pen. So here now this receptor is been occupied by another drug and replacing the drug which was before. So that is something reversible, means it can replace the receptor. Irreversible means whatever the binding of the receptor, when the drug or the any ligand will go and bind to the receptor, it will until the receptor is removed. That is irreversible. Okay. So reversible means it can, when an external force or excess of neurotransmitters will be just bombarding on that particular receptor, so it can change the place. Like suppose example, there is one chair in the class, okay, and there are 2 students or 3 students. So one student is sitting and the 2 students are standing, and what they will do, the one out of the stronger, what he will kick everybody out and he will sit on that chair. So what does that mean? So he's the stronger one, isn't it? So that is something reversible. So it can be interchangeable. So what the another person who has been kicked out will come with a stick and he will bring a gun and say, suppose, oh, get up, I want to sit here. So he will. So that is something reversible, changeable. Okay, it's a very bad example, but here I think the people will understand. Okay, so here this is something irreversible. Irreversible means the person who is sitting on that chair cannot be replaced, Okay, so that is something irreversible, like say ecothiopentane or physostigmine, neostigmine, and endorphin. These are the example of reversible and irreversible drugs which is present. So the synthesis of this acetylcholine, how does, like here, basically it's a process. This will occur into a nerve ending. So suppose this, if we take this is a nerve ending of this is, suppose this is the nerve ending. Acetyl-CoA enters with an exchange of sodium ion, which enters into the nerve ending, and then it will combine with choline over here, and it will form acetylcholine. And as soon as this forms acetylcholine, it will go make themselves safe in the vesicle. And this vesicle will be having an acetylcholine. It's a storage house of acetylcholine. And once the storage, whenever the body requires this vesicle, the storage of acetylcholine is moving towards the nerve ending, it will come and attach to the nerve ending over here. As soon as it comes and attaches to the nerve ending and the body requires some acetylcholine has to be released, and the acetylcholine will come out and it will go and bind to the muscarinic or the nicotinic receptor in the postsynaptic neuron. And when it will go and acetylcholine will come and combine with postsynaptic neuron, it will undergo some physiological change. Okay. And then what happened here, we say acetylcholine. So what we understand, the acetyl-CoA and the choline combines and form acetylcholine, and this acetylcholine is moved and the synapse. This is the gap between the 2 neurons. The gap between the 2 neurons is called synapse or synaptic cleft, or synapse or synaptic cleft. So here there is an enzyme that will be present here, acetylcholinesterase. So acetylcholinesterase will be here. If suppose the acetylcholine come in contact with acetylcholinesterase, it will break down into again acetyl-CoA, it will acetyl-CoA, and then choline, choline. So this acetyl-CoA again go back to the nerve ending and combine with choline in the neuron, and then again it will be formed acetylcholine, and this choline will be disappeared. So here, the basic point is this is a process of synthesis, acetylcholine, and it's a very big, lengthy process. Like there are so many ion channels like calcium, potassium, sodium, and these are the other things also involved. And exchange of gas, exchange of ions, which takes place a lot of things. And then the acetylcholine is getting released, and then once it is getting released, it go and bind and show some response. And if suppose if it is not binding to the postsynaptic neuron, then if suppose the acetylcholinesterase enzyme which is present, if it is catches the acetylcholine, it will break into two in the form of acetyl-CoA and acetylcholine, and then it will break down of acetylcholine. And the acetyl-CoA will go back again to the acetyl in the neuron nerve ending and again start the process of synthesis. So this is how a process of, that's why we say reuptake of this choline and acetylcholine that would takes place, okay, either way around like this. So this is how the process of synthesis of acetylcholine and degradation or the breakdown of acetylcholine takes place in the neurons and in the nerve endings. So this, whenever we talk about the degradation, like suppose it is splitting into two, that means that something, this it is because of it is happening in the synaptic area. Why I draw the diagram here, the pre and post synaptic, pre-ganglia or the pre-neuron or the post-neuron. Why? Because in the synaptic cleft, this process, this acetylcholinesterase takes place. This process, the second process, takes place. As soon as the acetylcholine release, if it is not binding to the receptor, it will be there in the synapse. As soon as it will come in contact with the acetylcholinesterase enzyme, it will be breakdown. So that's why I draw to make it more clear. So this is what it happened when acetylcholine is released, and it will go and combine with do the different activities. So, and here, based upon which binding site it is binding, I told like acetylcholine, say suppose this is coming to the heart, so example heart, and another post-neurotransmitter, acetylcholine is released, and it is coming to the skin, say example, and another, it is coming to the, say suppose, eyes. Okay, what are the functions will be? It varies in functions. Okay, it varies in functions. So what are those functions we will see? Okay, everybody clear by here now that acetylcholine photosynthesis process, what are the receptors here? Muscarinic and nicotinic receptors. Okay, acetylcholine is a basic neurotransmitter which is going and binding to muscarinic and the nicotinic receptor and showing some functions. And this acetylcholinesterase which is present in synapse, whenever it comes in contact with acetylcholine, it will break down the acetylcholine into two different parts of acetate and choline. And again, this choline and the acetate will go up and form a compound. Okay, and then again acetylcholine. So here, based upon the binding site, like here in the heart or in the postsynaptic area, in the heart or in the layer, then it will be having different functions. What type of difference in the functions we will see. So here, the pharmacological activity of acetylcholine, whenever it goes and binds to the muscarinic receptor of heart, what are the which receptor is present in the cardiac system is M2 receptor. M2 type of receptors is present in the heart, and as soon as acetylcholine go and bind to the receptor over here in SA node or AV node or wherever, and then in the heart, what it causes, it decreases the heart rate and it causes decrease in force of contraction. It causes decrease in force of contraction. Okay, and then here the next is vessel. So what is blood vessel? And what is receptor present here in blood vessel is M3 type of receptor, muscarinic 3 receptor. And this receptor is, which is something in causes vasodilation. Vasodilation means this will cause a decrease in blood pressure. And the same receptor, M3 receptor, which is present in the eye, M1, M2, M3. So we are here still we are here M2 and M3, and here this is like mesomyosis that might occur, means decrease the constriction of the pupil. The pupil size will become shorter. Why this is like happening? This is the acetylcholine is a rest and digestion process. It is parasympathomimetics. Okay, rest and digestion process, isn't it? So this is when the person is taking rest, this acetylcholine is going and binding to the heart and decreases heart rate, decrease blood pressure, and then it is causing constriction of the pupil. I hope that is all clear. And here the function of muscarinic receptor is like here glands, like M1 and M3 receptor. Based upon the figure, it will be having increased secretion and some are decreasing secretions, like here whenever they are going and binding. But the same thing, the acetylcholine, when it is going and binding to the skeletal muscle, where the 3 type of receptors are present, it causes the constriction of skeletal muscle. Here they contract the skeletal muscle, and that is suppose sometimes what happen, or the smooth muscles. Okay, in some cases, if suppose a person is suffering with stomach pain or something and stomach cramps, so if they go to the hospital, the doctor will prescribe him some antagonist of acetylcholine like atropine or atropine sulfate or thiazide, something else has been prescribed to the patient, atropine. What is this atropine? It is an antagonist of acetylcholine that stops the muscle cramps in the stomach, in the GIT. So that's why. Why? Because M3 receptors in the smooth muscle, in the GIT or in the skeletal muscle, that basically whenever acetylcholine come and bind to this receptor, it causes contraction of the muscles. Okay, so that's something what it will be working. And in the pharmacological action of nicotinic receptor, whereas in the skeletal muscle functions, whenever the drug will go and bind to the skeletal muscle in the nicotinic, it causes muscle contraction, and in the autonomic ganglia, it causes sympathetic activity, okay, visceral, and that may leads to preganglionic, postganglionic area, and then autonomic ganglia over here that is causing effector organ that to constrict or to cause contraction of the cell, that would takes place. Okay, so it's a small diagram for autonomic ganglia. What it is showing that whenever the central nervous system has pre and the postganglionic neuron where the acetylcholine is going and combining to the receptor is causing sympathetic or parasympathetic ganglia to get stimulated, and this can cause some stimulation that might occur in the autonomic region, in the autonomic ganglia. Okay, so this is how it's a little bit differentiation. When it comes to the central nervous system, acetylcholine injected IV does not penetrate blood-brain barrier, so no CNS effect will be seen. So whenever we are using acetylcholine, if we are injecting to the patient in IV dose, then it will be not crossing blood-brain barrier. So if it's not crossing blood-brain barrier, means then there will be no effect will be seen in the acetylcholine in the body. And the adverse effect of this acetylcholine will be something. What are the adverse effect here? So till now, I think everybody understood what is the effect of acetylcholine when it comes and binds to the muscarinic receptor. When it's binding to the muscarinic M1, M2, M3, when it's going and binding to the heart and the blood vessel, that is causing decreased heart rate, decreased blood pressure, and constriction of the pupil in the eye. And when it comes to the glands, it will cause increased secretion whenever acetylcholine goes and binds to the, like, suppose secretion. Increased secretion means the lacrimal secretion, saliva will be increased, hormones like thyroxine will be increased, GIT juices will be getting increased and helping in digestion, and M1 and M3 type of receptors, because the M1 and M3 types of receptors are present in that particular area. But when it comes to the smooth muscle and the skeletal muscle, M3 receptors, whenever the acetylcholine go and bind, it causes some constriction of the contraction of the muscles. When we come to the nicotinic receptor, the skeletal muscle, it causes contraction of the skeletal muscle, but whereas the stimulation of the ganglions will be seen when the patient is using getting acetylcholine in the autonomic ganglionic region. And acetylcholine injected in the IV form, it is having no effect because it cannot cross the blood-brain barrier. Okay, so here next thing is acetylcholine adverse effect. What is the problem that may arise? Whenever the person is causing excess of acetylcholine is getting released, it all causes diarrhea. The patient will be having excess of motions. Okay, dyspnea and meiosis means the constriction of the pupil, and feeling like nausea and vomiting because the excess of peristaltic movement will be in GIT, and lot of secretions. This is nausea because of excess of secretions in the body, in the GI tract, in the salivary. So if there is excess of secretions in the mouth or in the GIT, that may causes nausea-like feeling. And the patient will be having urgency in the urine, like suppose the amount of urine which will be expelled out will be less, but here always he is feeling, because the urinary tract, that particular area will be getting relaxed, and that may lead to excess of urine feeling, like urgency of the urine like feeling will be there. And the next is pilocarpine. Pilocarpine. What is pilocarpine? It is a pilocarpine. It's a drug that is obtained from the leaves of Paracolus miraculous. Okay, it is a stable hydrolysis of acetylcholinesterase, and this applied in the eye at the time of meiosis to decrease the intraocular pressure. So this is basically used in the case of glaucoma. So here, when we are talking about the eye, so what type of pressure it will be using? It is giving, okay, So here, if suppose if I draw a rough diagram of the eye, say suppose this is our eye, okay, this is our eye, the intra-auricular pressure at the back side. So at the back side here in the nerve ending, it is having a very high pressure. So here the pilocarpine is the choice of drug which is used here to obtain, which is obtained from the leaves of Pilocarpus microphyllus. Okay, so here this is applied in the eyes to reduces the intraocular pressure, means the tension, the pain in the eye. And the therapeutic uses of this drug is used in the intraocular pressure in the case of closed angle and the open angle glaucoma. So what is this glaucoma? It is nothing but a pain that will arises at the back side of the eye because of excess of intra-auricular pressure that is causing constriction of blood vessels in some cases. Okay, and here reserve effect of mydriatic after refractive testing. So here, whenever we are testing some drugs like atropine or the other drugs, and that causes to dilatation or constriction of the pupil, in that case, what we'll do, will make the mydriatic effect, means dilatation of the pupil can be done. In the case of acetyl pilocarpine, can use in improved muscle contraction in case of myasthenia gravis. What is myasthenia gravis? Myasthenia gravis is a condition where uh, where the muscles, the body, the skeletal muscle is become less strength, no power in skeletal muscle. The patient having a flappy muscles, okay, flappy. There is, like suppose he cannot lift, like a normal person, so suppose lift 5 kgs, that myasthenia gravis cannot lift 5 kgs, say example. This is not right, but just for the explanation I'm telling. So what happened? The muscle strength will become weak and the muscles will become flappy. There will be no contraction in the muscle. So this pilocarpine will help the patient to overcome the muscle proper contractions. And the adverse effect of this as a pilocarpine is it enters into the brain and causes central nervous system disturbance. Okay, the person will feel drowsy or a little bit hallucinated in sometimes. And sweating, salivation, and other secretions are increased. Means like excess of sweating will be there for in the body, and the patient will be having some salivation that may causes other issues. The next is anticholinesterase drugs. Okay, coming to anticholinesterase drugs. What is this anticholinesterase drugs? The anticholinesterase are indirectly acting cholinergic agonists. These are the indirectly acting cholinergic agonists. So the drugs which is acting indirectly. So now, like if you remember in the classification before, where what we did, what we said, they are directly acting and there are some indirectly acting drugs, isn't it? So here I'll just show you the classification. Here it is. Okay, so here when we say it is directly acting or indirectly acting. So we talked about directly acting drug like acetylcholine, betamethasone, or the pilocarpine. Now we are discussing about indirectly acting drugs, that is like physiostigmine, neostigmine, or icopentine, or this type of drugs. So here, what is indirectly acting drugs? The acetylcholinesterase are the indirectly acting drugs. This acetylcholinesterase is hydrolyzed acetylcholine to acetate and choline, thus terminate the action of acetylcholine. And acetylcholinesterase or acetylcholinesterase inhibitors are the drugs that inhibit the enzyme acetylcholinesterase, thus protect acetylcholine from hydrolysis, thereby increasing the action of acetylcholine. And this action of acetylcholine, here it is like a very beautiful diagram that is very easy to explain you now. So here these are the drugs, like suppose whenever, like I think I have drawn a diagram like presynaptic and the postsynaptic neuron. Okay, the acetylcholine, which is like this dots are acetylcholine, green or yellow color, because like I cannot really differentiate. So this color, the acetylcholine is getting released and is going and binding to suppose M1, M2, M3 type of receptors over here. And the acetylcholinesterase enzyme will come and blocks this acetylcholinesterase. Okay, so what these drugs are anticholinesterase. This anticholinesterase is going and binding to this particular site. I will change the color, I'll make it red color. This is the blue, and it will go and arrest this acetylcholinesterase. Once this acetylcholinesterase is arrested, then there will be no hydrolysis. If there is no hydrolysis, the amount of acetylcholine which is released in the synapse will be more than it is like it. Okay, because like what happened, whenever the acetylcholine is getting released, the acetylcholinesterase enzyme will coming and binding to it and causing degradation. So if suppose we are arresting, we are freezing this acetylcholinesterase for some period of time. So there will be no hydrolysis of acetylcholine. So whatever the acetylcholine is released in the synapse will go and bind to the receptor, isn't it? It will go and bind to the receptor of the postsynaptic, okay, postsynaptic area, and that may causes like action, increased action. So that's why it says like here the drugs which is acting over here are, what are the drugs? Ecothiopentine, endorphin, neostigmine, pyridostigmine. Clear, everybody? I think, is it clear or no? Or should I explain you one more time? What is anticholinesterase? Cholinesterase means it is an enzyme that will be, so when we see the synthesis, if you see acetylcholinesterase, here this is the enzyme. So this enzyme is basically breaking acetylcholine into two, acetate and choline. So what that anticholinesterase drugs are doing, indirectly acting, they are freezing this enzyme. They are freezing this enzyme. If this enzyme is get freeze, then there will be no degradation, no hydrolysis of acetylcholine. So whatever the acetylcholine is present, it will going and binding to the drug. Clear? Now everybody clear? So this is what we are doing. We are freezing this enzyme. That anticholinesterase is stopping the effect of this enzyme. Now it's clear now, everybody? Okay. Okay, so now it is clear, then it's good. I thought like you got a little bit confused over here, so that's why I came to the slide. So that's what it is happening over here. This acetylcholinesterase, this is the blue color, I think this is the blue or the purple color. This is the acetylcholinesterase, and this is getting blocked by this anticholinesterase drug, that is like endorphin, neostigmine, pyridostigmine, etc., etc. drugs. So what happened here? The reversible inhibitors like physostigmine, neostigmine, pyridostigmine, endorphin, neostigmine, donepezil, okay, etc. drugs. And the irreversible drugs are like organophosphate, okay, ecothiophates, sorry, and parathion, malethone, carbonate, carbyl, and peroxyl groups, and etc. These are the which is like comes under classify under anticholinesterase drugs, reversible and irreversible drugs. How they are acting? And they are active. They are arresting the acetylcholinesterase enzyme, and the amount of acetylcholine will be released. So what is the use of that? So here it is the used in neostigmine, pyridostigmine. The reversible drugs can be used in the case of glaucoma to decrease the intraocular pressure in the cases of the eye. Okay, and here atropine is poisoning. In the case of atropine poisoning, what is atropine poisoning? In the previous olden days, the people used to eat the flower of atropine, and that may causes like some severe side effects. So for to stop the atropine, that type of poisoning, this physostigmine can be given. In the case of myasthenia gravis, in the case of longer-acting drug, we can give neostigmine or pyridostigmine. What it will do, it will increase the effect of acetylcholine on the skeletal muscle, and the muscle strength, the life of the muscle strength will be increased. Okay. Acute toxicity, what can it can cause? Okay, the problems that may arise, the adverse effects that may arise in this case of acetylcholinesterase enzyme is like anticholinesterase enzymes are acute intoxication, must be recognized and treated promptly in the patient with heavy exposure. If suppose somebody has taken excess of these drugs, then what are the things can be happen? The meiosis, okay, the constriction of the pupil that may comes, arises, saliva, okay, excess of saliva means lacrimal secretion, the tears, excess of saliva, excess of sweating, feeling like nausea feeling or the vomiting or the diarrhea may arise because of excess of acetylcholine binding. And this muscular weakness is also a part, and respiratory and cardiovascular depression that may arises. Why? Because like why this depression is arises, like here respiratory or cardiovascular depression. So here I'll give you one example for to understand this properly, this toxic effects. Like say suppose here I will draw two diagrams. I will not draw one diagram. One diagram will be confusing. So suppose this is say suppose this is presynaptic and postsynaptic, and again this is presynaptic and this is postsynaptic. Okay, so here this is presynaptic is basically secrete acetylcholine, ACH. Okay, ACH, acetylcholine. So here, for example, the presynaptic neuron. Okay, the example, whatever the numbers I am telling is wrong, but this is for our understanding. Okay, if 10 acetylcholine is getting released, say example. Okay, there is no 10, there will be millions or thousands or millions of acetylcholine will be released at the time. Okay, so for our understanding, what I said, the 10 acetylcholine is getting released, and only 7 will go and bind to the postsynaptic neuron. Only 7 will go and bind to the postsynaptic. This is presynaptic and this is the postsynaptic. Okay, only 7, or suppose this is organ, wherever. So only 7 is going and binding to that particular site. Okay, where are the 3? Because the release is 10, whatever the acetylcholine is getting released is 10, isn't it? And only 7 is binding. What happened to the 3? The 3 is getting degradation or hydrolysis by acetylcholinesterase enzyme. Acetylcholinesterase enzyme. Okay, and that maintaining the 3, say example. Okay, so that is like maintaining a proper heart rate, respiration, and everything. So if suppose if we are giving acetylcholinesterase enzyme as acetylcholinesterase drug, so what happened is the 10 acetylcholine is getting released, and all the 10 will go and bind. How? Because the same synaptic cleft in the synapse, the whatever the acetylcholinesterase enzyme is getting arrested by anticholinesterase drug. It can be pyridostigmine, neostigmine, endorphin, anything. So this acetylcholinesterase is getting all the acetylcholine is getting that. That may sometime, if suppose it is this function is happening in the vagal nerve, in the heart area, that may cause decreased heart rate, and the contraction of the heart muscle will be decreased, and then that may causes cardiovascular depression. And if it is in the lungs, it can cause excess of secretions, and it can block relaxation of the lungs muscles. Okay, bronchus in that area, particular area. Okay, and excitement, and the convulsions and the coma, and that can be happen. So excitement can be seen, convulsions because what happened? Excess of contraction that may leads to some severe side effect, isn't it? That may causes this type of effect. And how can we treat this? I think this symptoms of this toxicity is been understood. Okay, so this is like here. So what happened? These drugs, it is stopping the degradation or hydrolysis of this particular acetylcholine by some extent. So here, if suppose 10, it's 3. If suppose 100, 30, if 1 million, it's 300,000, whatever. Okay, so that will be, you can imagine. So this is just for our understanding, like 10 acetylcholine is getting released, and only 7 is binding to the postsynaptic area. 3 is getting hydrolyzed, that is maintaining the proper body functions. If suppose we are arresting this acetylcholinesterase enzyme, so there will be no hydrolysis of any enzyme. Whatever the acetylcholine, like 10 or 100 is getting released, and 10 or 100 is going and binding to the receptor, showing some effect, isn't it? So that effect can be, if suppose that effect is on the CVS in the heart or in the respiratory or in the muscle, that may depress the cardiovascular system by causing decreased force of contraction and decreasing heart rate. If it is muscle, the muscles will become flat, muscle weakness that can be arises because of this effect. Okay, because of excess of contraction and excitation, the convulsion that may be arises in some cases. So here, the muscular weakness can be skeletal or maybe other, like sort of a smooth muscle where the blood pressure, so that can causes again dilatation of the blood vessels that can occur. Because we have seen what this acetylcholine is doing over here in the previous slide, that the acetylcholine is causing decreased blood pressure. It's a decreased blood pressure here when it is acting on M3 receptors, causing vasodilation. Okay, those type of effect can also be seen. So here there should be no confusion that should be coming, that should be arises. Okay, the treatment means like if suppose somebody has these acetylcholine toxicity, in that case the drug of choice, like how can we treat? We can have to block the effect of acetylcholine by giving some drug like atropine. What is this atropine? Atropine is a drug antagonist for acetylcholine, and parenterally a large dose given to and often required to control the signs of the muscarinic excesses. So this is something atropine can be overcome this type of toxicity, and that can stop the effect of acetylcholine. And the last slide is cholinesterase deactivators, so the drugs like drug used to reverse the inactivation of cholinesterase enzyme caused like organophosphate, which is irreversible drug like oximes, OXIMES, oximes or oximes, okay, whatever the way we have to pronounce, okay, that's like these type of drugs like organophosphate, what they act as an antidote for organophosphate and cause deactivation of the enzyme. So example is phenylidoxine. So this is a drugs like which is used for cholinesterase enzyme deactivators. Because it is completely blocked, and in that case, then we can use this drug to stop the effect of those drugs. Okay, so this is the organophosphate like which will be irreversible, so that can be reversed, and then the person will become as normal. Everybody clear? So if you have any doubt, like if there is any confusion regarding this, like okay, because like this topic is ANS is autonomic nervous system is little bit confusing topic. Like if suppose so, and I can guarantee you that like when you will come to the next class, like when you see anticholinesterase, or sorry, anticholinergic drugs or parasympatholytic or cholinol, okay, this type of drugs like that blocks the effect of acetylcholine. So whatever the effect, if you remember this, if you remember the effect of acetylcholine and the directly acting or indirectly acting, the same opposite effect will be seen in the next coming class when we study anticholinergic or when we study adrenergic or etc. etc. Okay, so this is something is for today's lecture. If you have any doubts or anything, you are free to ask, or if you don't have any doubts, then you are very good boys, or either way around, all are good boys. Okay, do you have any doubt or anything? Okay, thank you very much. I stop.